So what I want to talk about today is, first I'll give you a little bit of background, and then I'm going to review some programmatic principles for how to reduce stigma and discrimination. I'm going to review some of the key elements of stigma reduction programming, and give you some examples of some programs that were successful in various places. I'm going to go through a few resources that will be really helpful for you if you're thinking about doing stigma reduction work or integrating it into your current programming. And then I'm going to move, the second half of the presentation is going to be all around measurement. So basically, ICRW has been working on this topic since about 1999. And we really, ICRW's part of our mission is really to sort of build insight about topics so that we can catalyze action. And our stigma work over the past decade has really been an example of that insight to action model. Our work has mainly focused in terms of our stigma research in Cambodia, Ethiopia, India, Tanzania, Vietnam, Zambia, and then throughout South Asia. ICRW does all of our work in partnership, and this Stigma project really exemplifies those partnerships. We had over 20 implementing partners, which there's a slide of them all, from all of the countries in which we worked, and also a number of funding institutions that have supported this work. So this has really been a collective effort by a number of people, and all of that effort has brought together some really interesting knowledge and insights and action. Basically, I'm just going to talk to you quickly about this insight to action model in a sense. So we basically started with formative multi-country research in 4 countries, and the purpose of this was to disentangle and define stigma. Once we had that information, we used that to develop practical stigma reduction tools by working with partners on the ground to develop these participatory tools that really sort of honed in on all of the various domains that came out in the initial qualitative research. We then moved into developing measurement and evaluation tools. Once we had these tools, we thought, okay, now we have tools that we can intervene, but how are we going to know that we're successful? And there really wasn't a lot of information on how do we measure stigma and how do we measure change over time. So we did a lot of work in terms of developing measures and evaluation tools. And then after that, we moved into actually implementing piloting some of these stigma reduction interventions, and then using the measures that we had developed to evaluate whether they were successful or not. Following those interventions, we then had some data and some information with which to do a little bit of advocacy around. So we did this by developing some guidance documents we developed one for DFID, we developed one for UNAIDS, and we also developed strategy for the PEPFAR program in Vietnam in terms of how to go about reducing stigma. And so then following those efforts, we went on to do some technical assistance to a number of grantees. I'll talk a little bit about that today. The World Bank had a program called the South Asia Regional Development Marketplace, in which they funded 25 small grants all throughout South Asia, the 7 countries in South Asia, and we provided technical assistance to help them both design their interventions and also evaluate their interventions. And lastly, we've really moved into recently to do some modeling work to look at what are really the costs of stigma in terms of key HIV outcomes, such as infant infections, perinatal transmission of HIV, and that sort of thing. And then lastly, we've now moved into trying to facilitate knowledge sharing, and we're involved in a network called the Stigma Action Network, which I'll mention it a little bit later, which is a way in which we're trying to make sure that everyone who wants to do stigma reduction work has access to this information. So now I'm going to talk about some of the key programmatic principles for successful stigma reduction programs. So the main thing that we learned, or one of the main things that we learned in that initial formative research, is that there are really 3 immediately actionable drivers or causes of stigma. And the reason we say immediately actionable is these were things that we found could be shifted through programming in a relatively short time period. Of course, there are a lot of underlying drivers of stigma that might take longer to change, so we didn't want to not highlight those, but we just wanted to focus on what we think are these actionable causes. And these include lack of awareness of HIV and its harmful effects, fear of HIV transmission through casual contact with people living with HIV, so, fears about sitting next to someone, that sort of thing. And thirdly, values that link people living with HIV to immoral behavior. These really, out of the research, came out as the main actionable causes. And you really need to address these things at three levels: at the individual level, so in terms of addressing specific attitudes and behaviors; at the environmental level, so for example in hospitals, making sure that they actually have the gloves and things they need to follow universal precautions. Sometimes, simple things like that, if they're not in place, then that really influences whether or not you're going to be able to be successful. And thirdly, at the structural level, you really need to look at also at the policies, laws, and systems. So that's sort of an initial kind of framework of what you need to address. So the next key principle is really to create understanding and to close this kind of intention to action gap. One of the things we found is that you really need to foster an understanding and motivation for stigma reduction among the groups that you're working with. So you can do this by helping people to understand how to recognize stigma. Oftentimes, people didn't even realize that, say, for example, giving their son or daughter a separate plate or spoon or cup was stigmatizing and how that made their son or daughter feel. So we found that sometimes people just weren't really aware that their actions were stigmatizing, and that's something that can easily be shifted. So helping people to recognize what stigma looks like, and also the benefits of reducing it. And then really important is also to provide this safe space to reflect and gain skills. Another key principle for stigma reduction interventions is to address HIV transmission fears and misconceptions. There's a lot of stigma that's related to just basic misunderstanding about how HIV is and is not transmitted. And this is the kind of, these fears lead to the avoidance behaviors that are so common: not wanting to sit next to somebody, not wanting to shake hands, not wanting to hug somebody. So it's really important in interventions to address these sort of basic fears, and also to make sure that you talk about how HIV is transmitted and how it is not. That's often left out of our prevention messages, and so there's a lot of gaping holes and gaps in knowledge that people just aren't aware of. So that's something that's important to address, and also providing some in-depth information. As the epidemic in many countries has been around now for a number of years, and so basic knowledge about HIV is pretty high, but where people are kind of lacking still is the in-depth knowledge. So, for example, about PMTCP, about serodiscordance. So it's really important for people to have a very in-depth understanding, and that helps to reduce these fears. When you're doing this kind of knowledge sharing, it's really important to do it in an interactive manner instead of a didactic manner. We found all of our tools are very participatory, and this really allows for those kind of questions. Yes, I know that you can't get HIV from kissing, but why? Or those sort of, to allow for those sorts of conversations. And then lastly, to really listen, learn, and respond to specific fears related to daily context. So what we learned is that pretty much anywhere you go, these underlying drivers are going to be the same, but they're contextually specific. So in Vietnam, people might be afraid of becoming infected with HIV when they go to a manicurist, whereas in Tanzania, you might be afraid of getting in a minibus accident, and you happen to be sitting next to a person living with HIV, and there are fears around that. So it's really important to kind of understand what are the specific fears that people have in their daily living so that you can address those specifically. And the next really key principle is to discuss and challenge the taboo. So this really allows, it's really important to provide a safe space during these participatory sessions to really discuss, reflect, and understand and question two things: these kind of values and beliefs that underlie stigma and discrimination. So where are these beliefs coming from, and what do they do? How are they harmful? And also, it's really important to provide a space to talk about gender, inequity, sexuality, violence, and drug use. This is really the last sort of stigma reduction principle is what we call the start at home principle, which really means to just, before you kind of go out in the world and try and help other people reduce stigma, it's best to sort of take a look at your own institution, organization, and your own views and really allow that space and support to reflect on, sort of evaluate and change organizational level, whether it's policies, attitudes, practices that may actually be stigmatizing in some way, and also on an individual and personal level. And this also really helps, your staff to build their skills and ensure that they're not sort of stigmatizing inadvertently. And also it provides a chance for ongoing support for learning and change. Okay, so next I want to move into the key elements for a successful stigma reduction program. So I have a few slides where I'll show you. You'll see some pictures from various stigma reduction interventions that have been done around the globe. And what we found, sort of looking across all of these interventions, is a few key elements that are really important in order to have successful programs. So the first element is really to ensure that gatekeepers have both understanding and ownership over the project. So this can take a lot of time, but what we've found is even if it takes 6 months to get the senior folks on board, whether it's the Communist Party in Vietnam, the Ministry of the Hajj and Islamic Affairs in Afghanistan, the Parliament in Nepal, it's really key to have those discussions before you start your interventions, because if you can bring these people on board, they can both open up avenues for allowing you access to various things, and they also make it really easy to scale up. And it also makes it easier to go into town, especially we found with the programs in Afghanistan, since they had the letter from the ministry, they could go around to the imams and say, hey, look, it's okay that we've been told that we can do this, we can give these trainings, and that really carries a lot of weight. So we found that in a lot of contexts it's really critical to first start with these gatekeepers. One of the next key sort of elements is to involve multiple change agents. This really helps involving multiple people in the process as opposed to just having this sort of didactic type of intervention is really helpful because it facilitates interaction between, for example, people living with HIV and the police or, children and students and that sort of thing. So to make sure that you're really thinking about involving as many change agents as possible in your intervention. And this also helps to kind of model and uphold desirable behaviors. There was a really interesting project in Mysore for the World Bank SARDM, and it was a group of sex workers. It's the picture on the right. There was a group of network of sex workers that basically opened a restaurant in which sex workers and transgendered individuals were working, and that was part of one of the ways in which they were attempting to reduce stigma, to open this restaurant and have people come in and actively engage. And they actually did a lot of work with the local police, and that's the sort of chief of police coming to cut the ribbon on the day that the store opened. So those are the sorts of things, not only that oftentimes we don't maybe think about, but to have sort of look for those change agents and then have them help you to really model the good behaviors that we want people to ideally be adopting. This also helps to create alliances and form new partnerships. There was another program in India in which a network of sex workers also worked with the police directly and with healthcare workers, and they found that, especially with the work with police, the police realized, there are all of these issues, and maybe we can, and stigma is an actual thing it's sort of a bad thing to happen, and so they actually started, women were going and reporting cases of discrimination, and the police were getting involved and going out and helping to reduce some of, or really take those problems on. So whereas before this network of sex workers was very fearful to be involved at all with the police. So it just shows that you can make some great strides by actually sort of forming these alliances and partnerships. The next really key element is to use a range and combination of approaches. In our intervention research in Vietnam, we found that the more activities people were exposed to, the greater improvements you saw. So the greater reductions you saw in their negative attitudes, and the more improvement you saw in their positive behaviors. So it's really important in interventions to use this kind of range and combination. So this could include participatory learning sessions, which you can see top left. It can involve community meetings. We also found that it's, especially in a lot of the South Asia work, that using cultural mediums is really critical. So, for example, you can see in the top right, this is a traditional dance and singing group in a certain region of India. That's really kind of the really important cultural medium. And this group adapted and developed songs about stigma and stigma reduction, and that's how they were getting their message around, and that was really powerful. In the bottom left, you can see another group from India that used the traditional theatrical sort of medium to get out their messages about stigma and discrimination. So those sorts of utilizing those cultural mediums are really important. It can also be really important to have written materials that are of local relevance. In the Vietnam work, they developed a lot of materials that could be delivered directly to the home that had very good information about both HIV and stigma, and this was found to be a very important element in that intervention. And lastly, there's a range of media channels that you can use, whereas your typical channels, posters, those kinds of things. You can also involve the radio. Some radio programs have been very successful at addressing stigma. And just to be creative, in Vietnam, they actually used the loudspeakers. They had messages put out over the loudspeakers that are often used in communities there. So this just gives you an idea of some of the approaches that have been used thus far that were found to be successful. Okay, another key element is to really effective efforts we found are often led by or continuously engage marginalized communities. So this is really, really critical. Is to really make sure that people living with HIV and other marginalized groups are really front and center in any stigma reduction intervention. This helps to address self-stigma that people living with HIV and also marginalized groups often face. It can be very empowering. It helps develop and support networks of people living with HIV and other key populations. It provides capacity strengthening. So, of course, training in terms of new knowledge and skills around, for example, advocacy or income generation. And I think it also really ensures that you'll be able to carry on projects after you leave. Is that if you've trained this group of people that are very motivated and passionate about the issue and are affected by stigma so heavily, that it really helps to ensure that after whatever program ends, those efforts will be able to continue. And it also ensures that people living with HIV and marginalized groups, I shouldn't say it ensures, but it helps to, them to get access to prevention care and treatment services as well. So now I just want to briefly talk about, so those were the key elements of successful programs. I just wanted to briefly mention some tools that are available. This toolkit that you see on the left here, Understanding and Challenging HIV Stigma, this was developed out of that 4-country study that I mentioned back at the beginning. It was developed, several years ago, I would say almost a decade ago now, and it uses a bunch of participatory methods. So it's a toolkit with a bunch of exercises in it, and it's been successfully used now with a wide range of audiences. So you could be talking to the general public, police, parliamentarians, groups of people living with HIV. It has a bunch of exercises in it that can sort of be adapted for any audience. So far it's been used in over 40 countries. It's available in at least 7 languages. We're always learning about more. And it's really a living document. So the idea is that you can sort of take it and adapt it as you need. So basically, if you look on the right-hand side, you'll see that this tool has been adapted for a few specific populations. So we actually just did an adaptation in Vietnam, so we now have a toolkit that's specifically addressing injection drug users and HIV stigma. We also have one in Vietnam that's looking specifically at stigma towards sex workers and HIV. And then there's 2 toolkits available in Cambodia, one for addressing stigma towards men who have sex with men, the other for addressing stigma towards entertainment workers or sex workers. And then there's another kind of adaptation in India that looks at how to reduce both stigma and gender-based violence. And this is just a sampling of some of the adaptations. So just to say that there are tools out there that are ready for use, and there are also tools for specifically addressing stigma in the healthcare setting. So this is a second resource that I want to tell you about is the Stigma Action Network. I won't go too much into the history of the network, but this just launched last year, the network that is, and the idea is really to help sort of enable the scale-up of stigma reduction efforts globally by providing a space where people from a range of different sectors, so, groups of people living with HIV, advocates, researchers, donors, policy people, can all sort of have a place to come and access information, and also to kind of foster some networking across sections. This was found to be sort of a main gap that's sort of preventing us from being able to really scale up programs, was this lack of both available information that was easily accessible, and also this lack of communication across these groups that sort of left a lot of people working in isolation and kind of reinventing the wheel. So I just wanted to let you know about this resource. The website launched in May. It has over 600 resources in the electronic library, and all of those tools that I mentioned and a lot more are there, and they're accessible for free for downloading. So please do take a look and tell your colleagues about it to make sure. We really want to make sure that the word gets out that this resource is available now. And just to say that since May, we've had over 2,100 visitors from 109 countries, so that's pretty exciting. Okay, so the next part of the presentation is really around measuring the results of stigma and discrimination efforts. So currently there's, in terms of measures for evaluating a program, there's some measures that are recommended that actually ICRW and others have developed and tested that are really targeted specifically at understanding these immediately actionable drivers. So the measures were developed to ask specifically about lack of awareness of stigma, fear of infection through casual contact, and the values linking HIV with immoral behaviors, or shame and blame. And also there were measures that were developed to assess the manifestations of stigma, so the experiences of stigma and discrimination of people living with HIV, and also witnessing or hearing about those experiences if questions are being asked in the general public. A caveat, I'm going to go through some of these measures just so you have a sense of what the questions are. But a caveat is that there's a global group that's really working to review all of the existing measures and come up with some new indicators. And the results from that should be coming out very soon. So just to say that while these are the current measures, these might likely change or be expanded in the near future. Just to give you a sense of the type of measures that can be used to assess fear of infection, these 5 questions are recommended for asking about this domain. So, for example, you might ask people if they fear being infected with HIV if they touch the saliva of a person living with HIV, or the sweat, that sort of thing. There are a few questions to try and get at the values and judgments, social judgment domain. So there's a few to assess shame. So you can ask people whether they agree or disagree with these statements. I would feel ashamed if I was infected. I would personally be ashamed if someone in my family had HIV. And then there's a few questions around the blame domain. HIV is a punishment from God. It's a punishment for bad behavior. And these items can actually be made into small scale, and I'll show you that in a moment. And then, as I was mentioning, we also have developed a bunch of measures to assess the actual, what we call stigma and discrimination experience, or enacted stigma. So this comes from the formative research. These were the most common types of stigma and discrimination that people living with HIV were experiencing. So you'll see you ask people whether they are aware of or have seen incidents of these things happening. So there's a few things in the category of isolation. There are verbal stigma, loss of identity and role, and loss of access to resources or services. So these can actually be asked of people living with HIV directly. Have you experienced this in the past, 12 months or something? Or you can ask people in the community, have you seen this happening, or are you aware of this type of behavior? So I just want to give you 2 quick examples so you can see how these measures have been used in the past. So this is an example from one of the SARDM projects. It was a group in Pakistan called Integrated Health Services. And they were conducting an intervention in universities in Islamabad. And what they did is they established youth and HIV forums at 5 colleges and universities. And then they did sort of a pre- and post-intervention survey. They had at these youth forums, they had, some training in a sense on, HIV and stigma. And then they did a lot of other activities related to reducing stigma in their communities. So So the findings from this evaluation showed that knowledge had increased and fear, shame, and blame had reduced. So, for example, the percent of students agreeing with the statement, people living with HIV should feel ashamed of themselves, decreased from 25 to 9% by the end of the intervention, and the percent of students afraid to share utensils with people living with HIV decreased from 32 to 10%. So that's just one example of how the measures were used in that type of intervention. So this slide comes from we did a community stigma reduction intervention in 2 communities in Vietnam several years ago, and we asked a number of these measures, and you can see that between baseline and end line, the percentage of people agreeing with these 2 fear statements, that they were afraid to share an inpatient room with a person living with HIV and that they were afraid to have a manicure, decreased between baseline and end line in both communities. In terms of the value-based stigma, you can see that there was also a decrease in the percentage of people agreeing with the statements HIV and AIDS is a social evil and IDUs are to blame for spreading HIV in our community. And just to say that we then went on to do multivariate analysis. We constructed scales with the various items in the fear domain and the value domain. And we saw, after controlling for a number of factors, we saw significant reductions in the scores on both the fear and shame indices following the intervention, which indicated less fear and less shame. So that's just to give you a sort of a flavor for how these measures have been used in the past. So the last thing that I really want to talk about today is developing this process that's been going on globally for the last 2 years to develop standardized stigma and discrimination indicators for program evaluation and national and global level reporting. So this work is funded through UNAIDS, and it's a collaborative process between IPPF, GMP+, Hopkins, Futures Group, and ICRW. A little bit of background on this next slide is that one of the big sort of gaps was that there's hundreds of measures out there to measure stigma, but there's a lack of consistency in how it's being measured. So the question wording is often different, the response categories are different, the domains being assessed are different, and this really limits our ability to evaluate stigma reduction programming, to improve programs, and to compare data across context, and to use this evidence for scale-up. So in order to address this gap, these 5 organizations sort of came together and formed this partnership, and then have started off down this track of trying to make some headway in developing new indicators. So the first step in this was a meeting that we held back in November of 2009. The objectives of the meeting were to come to consensus around the key areas that need to be measured when assessing stigma, including stigma towards groups most affected by the epidemic, to prioritize a minimum set of measures for each area, identify gaps where new measures need to be developed or improved, and agree upon next steps. So this was really the first step in this longer process to arrive at a set of program, national, and global level indicators. So I just want to briefly walk you through some of the key outcomes from this meeting. The first thing that's really important was that the meeting participants noted that all individuals stigmatized or be stigmatized. Oftentimes you'll see measures that are specifically for people living with HIV and people who are not infected with HIV. And so we decided that from the get-go we would think that we would think about people being either stigmatizers or being stigmatized, but that anyone could really fit into any category. And we also thought it was important to measure the following areas among all target populations where relevant: fear of infection, prejudice and stereotypes, anticipated stigma, internalized stigma, experienced stigma, and stigma by association or secondary stigma. Other measurement areas that we thought required further exploration were intersecting stigmas, which I mentioned earlier, institutional facilitators of stigma, so laws, institutional policies, and social norms. There's a big gap there, and there's some work being done to try and develop better measures around this area. Attributes of coping with or resisting stigma, so measurements around social mobilization and advocacy, and measurements around awareness of stigma and its harmful consequences. So I know we're running short on time, but I want to walk you through the framework that we developed. So after this meeting, what happened? Oh, next slide. What happened is that a 16-member global stigma and discrimination indicator working group was formed, and the first task of this group was to develop a practical framework to inform both the implementation and the measurement of stigma reduction efforts. So I say practical rather than conceptual because we decided that we only wanted to include factors that we could actually shift or change through programming efforts. So the whole thrust of the framework is really to help people understand where do we intervene and where do we measure and what do we measure. The working group agreed that there were really three main target populations for programming and measurement. So these include the general public, people living with HIV and other key populations, and institutions such as the healthcare systems and the government. So anything you do is going to need to be targeted as much as you can at each of these three populations, both in terms of programming and measurement. So that you can see that they're sort of underlying the framework. Okay, so in the framework, the first thing we depict is the actionable drivers and facilitators of HIV stigma and discrimination. And I mentioned before that we use the term actionable to refer to factors that can be shifted. These actionable factors can really facilitate and drive HIV stigma, or the marking of individuals or groups as socially unacceptable based on behaviors, characteristics, and HIV status. And this then manifests for individuals and groups in several ways. So these manifestations influence a range of outcomes which ultimately impact individuals and societies. So you'll see that the actionable drivers and facilitators and the manifestations are highlighted in green. And this is really to highlight that these are key areas for intervention development and scale-up, as well as measurement. And if you look at the top box on the left, you'll see that this indicates that there are already a number of existing measures that can be used to track progress related to stigma outcomes and impacts, including routine and behavioral surveillance, as well as program monitoring. Lastly, I just want to note that while this framework focuses specifically on HIV stigma, that the working group recognized that, oftentimes people experience stigma from multiple fronts. So you'll see on the right-hand side that we have other stigmas, and that's sort of underlying the whole framework. This is really an area that requires more attention and research, this area related to intersecting stigmas. So, okay, now we'll sort of take a closer look at some of the elements in the framework. The key actionable drivers of stigma include institutional and cultural facilitators, which can either positively or negatively influence stigma. So, for example, anti-discrimination laws and policies can protect against discrimination, whereas laws that criminalize HIV can propagate stigma. However, the individual and community-level drivers that are highlighted in the orange box, including lack of awareness and its harmful consequences, fear of infection, fear of societal and economic ramifications, and social judgment, these all negatively influence stigma and discrimination. Once the stigma has been assigned to individuals and groups, it can manifest in four key ways, including anticipated stigma, which is really the fear of negative social ramifications if one's HIV status becomes known, or if one associates with a person living with HIV or tests positive. Internalized stigma, which is really the level of endorsement of negative beliefs and feelings associated with HIV about themselves. Experienced stigma, which is the actual experience of prejudice and discrimination based on HIV status or association with a person living with HIV. And this is, I should say that the group decided to separate experienced stigma that falls outside the purview of the law and discrimination, which is the experience of prejudice and discrimination, but there are things that fall inside the purview of the law. So that's why you'll see a slight distinction between experienced stigma and discrimination. And like I said before, this framework is really based on the assumption that all individuals can either anticipate, internalize, experience, and or perpetuate stigma discrimination, and therefore we decided not to distinguish between specific outcomes on the basis of HIV status. Okay, so these manifestations of stigma can lead to a number of negative outcomes for both infected and uninfected persons that really undermine HIV prevention, care, and treatment efforts and ultimately influence the course of the epidemic. You'll see a few stigma outcomes listed here, including risk behaviors, uptake of HIV prevention, care, and treatment and support. And these outcomes then influence quality of life, people living with HIV incidence, HIV prevalence, morbidity, and mortality. So I just want to quickly talk you through where we are currently in coming up with measures now based on this framework. So there's a few different efforts that are sort of going on concurrently led by different groups. So the first one I've already been mentioning is this Global Stigma and Discrimination Working Group. We're in the process of developing numbers for the general public. These would be measures that would ideally make their way into demographic and health surveys and ideally into surveys that people are using to monitor their programs. So we've just field tested 5 indicators in Rwanda and are conducting the analysis at the moment. And these indicators are assessing 5 domains that you can see listed here. In terms of people living with HIV in key populations, many of you may have heard of the HIV Stigma Index. This is an effort that's being led by GMP+, IPPF, ICW, and UNAIDS. And this is a tool that's implemented by people living with HIV. And currently it assesses 4 domains of stigma, which you can see listed here. And then in the category of institutions, the Futures Group is currently leading a process to develop a standardized survey for healthcare workers to be used in the healthcare setting. And it assesses 6 domains. And theirs actually includes some questions around institutional policies and structural facilitators, as well as new questions to test key population stigma. As you might notice from who is involved in these, we're all sort of working on this together. And so the nice thing about that is we're trying as much as possible to enable triangulation across these populations. So looking at what are we asking among the general public, and can we also ask that in institutions, and can we also ask a similar question among people living with HIV, so that the idea is we have these 3 sort of sources of data that we can use to try and figure out what is going on in terms of stigma and discrimination in a given country. So these efforts are all sort of going on simultaneously, and everyone's in close collaboration around these efforts, and we're really hopeful to have in the next year or so some guidance around measuring stigma across these 3 populations. The Futures Group work is going to be field tested in about 5 or 6 countries, so that's probably going to take a little bit of time, so I would expect that might be 6 months to a year before we have results from them. So this slide just gives you a flavor of the indicators that we tested for the general population. There were, as I said, 5 domains. In the domain of anticipated stigma, this was really interesting. We decided, and this hadn't ever really been asked before, to ask people if they agreed that people were hesitant to take an HIV test due to fear of people's reactions if the test result is positive. And it was pretty amazing. Over 50% of people responded yes to this question in the Rwanda survey. So clearly, stigma is a factor that people are considering in terms of whether or not they're taking an HIV test. Now, we do already know this in a sense from our qualitative work, but it's really, I think, going to be very powerful to be able to have an actual number that we can take to donors and other groups and say, look, this is a huge problem. 5% of people are not willing to take an HIV or hesitant to test. We need to do something about this. So that's one of the things that this group was trying to think about, was coming up with measures that were both very useful for our own programming purposes and for evaluating interventions, but also that would generate the sort of data that we need to convince policymakers to pay more attention to this issue. So we're hoping that question might help us do that. In the area of perceived stigma, so percent of respondents who agreed that people living with HIV are stigmatized or discriminated against. So we actually asked a series of questions about whether people living with HIV lose respect or standing in the community, and agreement was quite high with those as well. We asked a few questions around fear of infection, tested a few in the social judgment domain, so percent of respondents reporting that HIV is shameful. And then we tried a new discrimination question asking about whether children living with HIV should be able to attend schools, because this is becoming a huge issue in a number of countries. So the results, we're actually conducting the analysis right now, and we should have the results by the end of December, and then I will be sure to circulate them through the Strive kind of group and listserv so that everyone can know what the final results were and what we ended up recommending. So in terms of the next steps, I just was mentioning that we're finalizing the results of this, and then I'm not sure if you're familiar with the UN Monitoring Evaluation Reference Group, but they're sort of the gatekeepers for all measurement related to HIV. And so the process is that if you have new indicators that you want to recommend, you have to make a recommendation to this group, and then this group will review them, and if they approve the measures, then that means that they're sort of sanctioned for use. I guess they sort of have a gold seal of approval, and that means that they can then be integrated into, for example, reporting for PEPFAR, reporting for the Global Fund. And the idea is to really harmonize across these institutions and come up with measures that can be used across the board, which will really help us to come up with the data that we need to be able to compare across countries and to really advocate for the scale of a stigma reduction effort. And then ideally following that, we would work on developing some guidance documents to disseminate around how you implement these measures and surveys and how you construct the indicators and use them in analyses. So that's it. That's all I have today. So thank you very much for your time.
I have a question really about sort of targets of interventions and targeting the use of the toolkit, I guess, because in your previous presentation you talked a lot about the structural component of stigma being, a key underlying component, that this is about power inequalities among different groups in society, and that HIV feeds very well into systems of inequality. So in terms of using the kinds of tools that you're talking about in order to kind of get into that structural level, I thought that the example you used of the opening of the transgender restaurant being run by transgender people is kind of an example to me of something that isn't necessarily about HIV, but is very structurally sort of consistent with the kinds of things that we're talking about in terms of working on stigma at different levels. So I don't know if the toolkit resource focuses mainly on HIV or if it also is focusing on some of these other issues of inequality and who the best targets are for various bits of the use of that resource. Does that make sense?
Yeah, sure. No, that's a great question. Thanks. So I think the initial tool, the first tool that we developed really did focus specifically on HIV stigma. But over time, it's definitely expanded to include a lot of other issues around sort of other populations that would be stigmatized and issues around power and inequality and all of that. So, for example, I was mentioning that we now have toolkits to look specifically at stigma towards injection drug users, men who have sex with men, sex workers, all sort of in relation to HIV. So in those toolkits, there will be specific sessions about those key populations, but then there's always a bit about HIV to sort of link the two, because the sort of intersection of stigma that's happening, and people are facing stigma for multiple reasons, in a sense, or on multiple fronts. And that's an area that where we're trying to get more involved, and we're trying to understand a bit more about how those sort of multiple stigmas influence people. So these new tools are in an effort to really address some of those issues. One of the things we found in our research is that you can go out and you can do your stigma reduction intervention, and you can measure change over time, and you can see, there was a 10 percentage point reduction in fear, but it only went from 80 to 70%, and we realized that specifically in Vietnam, because the stigma towards injection drug users is so high, you can't be successful at reducing HIV stigma unless you're also addressing IDU stigma. So that's sort of a lesson that we've learned over time, and depending on the country, there are different populations that are seen to be the most risky population, and different issues around stigma. So definitely the tools are, I would say, being adapted to be more broad in terms of what they can address in terms of populations, but also to say that in terms of the structural issues and the target audiences, these tools can really be used at any level and with any population. So one of the things we found is that oftentimes when you're talking about the structural level, you're thinking, okay, policymakers, and sometimes it seems a little bit daunting, but there are individuals within all of those structures, and it's those individuals' behaviors and attitudes that need to shift, and once those individuals with the power, when their behaviors and attitudes shift, then they can make it possible to have change at that structural level in terms of policies and laws and all of that. So one of the things that we've found is important is to just remember that there are people in all of those institutions that are sort of the gatekeepers, and these tools have been really successful at enabling different groups to target those groups as well.
Yeah.
Does that help, Catherine?
Hi. It was a really interesting presentation, and thank you for making it all very clear and helping me understand a bit more about the different issues around stigma. I was wondering, you were saying about the different work that's underway and the development of questions for health providers.
Mm-hmm.
Is that exercise that we're doing? I was just wondering what time frame that's happening, sort of if that might be something that we can access and use, with the RPC and things like that.
Yeah, sure. Actually, we're literally, Laura and I believe, leading that effort, and we have a smaller working group that we're just finalizing the questionnaire. That I'm sure she would be happy to share, and that's what they're going to field test it through some researchers who have NIH grants in a few different countries, and I don't know when they'll actually have the final results. I would imagine that would be, probably 6 months from now, but I think in the meantime, we could certainly share the questionnaire, as people are, either developing proposals to do work in the healthcare setting. These are, questions that many of them have come from previous work, and then there's a whole host of new ones that we've also developed. So, we could certainly share whatever we have.
I just wanted to share that at the Asia Regional Office of ICRW, we have received a grant very recently from UNDP, in which just about 10 days back, where we would be adapting the global stigma reduction framework that ICRW, what Anne just now presented, in 5 different settings in India. We would work very closely with the National AIDS Control Program and the 5 NGOs, something on the line of the South Asia market, the World Bank program of what was done a couple of years back. But then we would have an opportunity to test some of these indicators and the implementation of the framework in different settings. So we would be sharing that soon, that experience, and we will be happy to really discuss at length how we fit this piece of work within the larger structural drivers of our program. So I just thought I'll share with you that we are about to initiate a program on adaptation of this global stigma reduction framework in India.
Great. Well, congratulations on the grant.
Yeah.